our participants. We're just letting the audience start populating in, and I'll just go ahead and start saying some of our background information, which I think the team can chat those things out to the group. And one thing that I would like to have chatted out is that those operations questions should be emailed to Albert Yeam at albert1030@berkeley.edu and not to the group generally. We don't want to interrupt our presenters with distracting chat. So with that, I'll just say that I'm thrilled to be still standing after this pandemic. I'm thrilled to have our wonderful leaders with us after this very trying time. And I'm just so grateful that the pandemic has settled down a little bit. It's not over by any stretch of the imagination, but it is a little bit of a lull, a little bit of a breather. And I'm just so grateful for all of you gathering together from around the state to help share best practices. This is approximately our 308th gathering of the University of Best Practices in the state of California. This project first started on my desk in 2006 in the Director's Office of the Department of Managed Healthcare. It's now housed at the UC Berkeley School of Public Health, and it is funded through donations from our wonderful supporters, Blue Shield of California. Thank you, Dr. Flynn, for being our internal champion there. California Department of Public Health, Los Angeles Department of Public Health. We have amazing volunteer support from the University of California across the many campuses, and we are housed within the Center for Health Outcomes and Innovation Research at UC Berkeley School of Public Health. Our supporters include the California chapter of the American College of Cardiology, the Stroke Awareness Foundation, and the Tennis Getter Family Foundation, and our amazing biopharmaceutical supporters who have helped to get us through the pandemic. Where would we be without them now? Johnson & Johnson and Novo Nordisk were two of our earliest supporters, along with Genentech, and more recent supporters, Boehringer Ingelheim, Amgen, and Amarin. The Health Trust of California funded our work with the Santa Clara Community Clinics. And with that, I'd just like to say all of our materials are available on our website, and we are working to package up much of our materials for Enduring CME that we're trying to put together with the University of California, Irvine, another wonderful partner organization. Next slide, please. So most of you know me since I've been running this for 15 years. Next slide, please. Next slide, thank you. So a recent accomplishment that I'm just thrilled with is based on the teamwork, which is what the Right Care Initiative is about. And I want to say that I'm inspired to do this work day in, day out, as many of you are, maybe a little bit, 7 days a week, trying to back that down a little bit. But I'm inspired because of the men and women like yourselves who are just totally dedicated to the public good, just like my mother was. She unfortunately was, like me, quite a workaholic. She was a linguist, talented in 7 languages, and as is the case with so much of the military and so many of our health professionals, she was on high alert all the time. She was just a delightful human being, and she unfortunately had hypertension, and it wasn't under control, and she died of a stroke when I was just 15. So I was motivated when I met a a community member who told me that she had a hypertension reading of over 180 when she went to get her eyes checked. And I was just thinking, gosh, our website is just not situated to help this woman, despite all the wonderful presentations we've had over the years. So I worked with Albert Yeam this week, our wonderful pre-med. Albert, why don't you come on camera and wave? Albert works on our website and does so many other wonderful things as a pre-med at UC Berkeley. And he helped me to curate resources from CMS and the Million Hearts Program, the American Heart Association, the Go Red for Women, et cetera, to make some patient-focused materials available. And we'll try to build out more of that. And I just want to call out Bill Baumer, who I'm about to introduce, for his wonderful leadership in improving hypertension control, not only in Sacramento, but across the state. So that's a picture of him using a wonderful, inspiring way to get his message across. And maybe, Bill, you can mention a little bit about that, about how you conceive of the umbrella image to help patients get their blood pressure in good control. Next slide, please. I'd like to introduce our wonderful statewide chairman, cardiologist, William J. Baumer. He is a champion for the state of California, not just the Right Care Initiative. I nominated him to be the chairman of the statewide cardiovascular disease master plan, which we'll be working together with the state to update over the next year. And he has trained many of the cardiologists from in California and beyond. And he leads a really important clinical quality improvement program for the state of California on making sure the quality is good in hospitals for various cardiology interventions. Next slide, please. And with that, I'll hand it over to you, Dr. Baumer.
Well, thank you very much for that introduction. And we certainly all are on a team. And that team is, our approach is to try to reduce cardiovascular disease. And one of the ways is by reducing risk factors, which we're showing here. And Hattie earlier showed blood pressure response. And I know that for those who've been in the medical world for many years, at one point, a blood pressure of 170, 180 was tolerated in medicine. And obviously, we gradually brought that down under 160, then under 150, then under 140. And now in the slide that she showed, we were talking about some of the details in the SPRINT trial, where we now compared it under 130 versus an attempt at under 120 in that population, showing that people with additional risk factors, there was an advantage and a tolerability to those lower goals. So we're always pushing to try to further prevent and what we call get to zero. Get to zero risk factors allows us to potentially get to zero risk of death and cardiovascular events. So what we have up here is a little bit of what we do, which is monitoring. You can see the 4 counties on top. And what we're looking for is blood pressure control. Now, obviously, since blood pressure is a significant risk, we'd like to be at 90 to 100% on all of these. And we keep working at it, trying to get up from 50% to 70% was an effort. But I think over the years, it's been progressively improving for each of our counties and groups. But there is a diversity here, meaning there is some high performers and some low performers. And part of what our process is to get those high performance techniques available and to all of our clinicians and all of our patients so that we can gradually improve it. And so what you see there is a monitoring effort. And you would say, we're going to discuss a little bit later today with our CMS speaker, monitoring for the CMS program. And I think that is an important part because we're not always aware whether we're doing a good job or not. And sometimes we have to be monitored and then told how we're doing. And that actually, I think, helps us to improve our overall performance. So you can see the performance here for blood pressure that we have for blood pressure control that is listed there, and that we do monitor it in many groups. And we're getting to the point where we can presumably monitor it across the state of California to try to improve it in that situation. Next slide. And some of the goals that we have are listed here in this triangle. The triangle looks like a summit that we're trying to climb. And yes, we're trying to climb it with proactive outreach, with home blood pressure monitoring. We want it patient-centered. We want it part of a team-based approach. And I think that's very important. And without going through every one of the protocols listed here, what the emphasis here is team approach of multiple participants for this, including the patient, patient's family, and the entire healthcare team that is available to us to enforce that or to allow us to control the blood pressure in that particular situation. So our target is always lower is better. Next slide. So we're happy to have the presentation today, which is going to dwell or introduce initially an additional aspect of vascular disease, and that is associated with chronic kidney disease and screening, identifying the risk. We all know that the kidneys are rich in blood vessels, and sometimes, such as the canary in the coal mine, the earliest sign of vascular disease may be changes in the kidney function. So kidney function is actually not hard to monitor. We have the ability to get urine analysis, obviously very easily, as well as blood tests for it, which can early on detect vascular disease that may be throughout the body, but is expressing itself first and foremost in the kidneys. So we're happy today to have a presentation that we're going to see that's going to address chronic kidney disease and screening, identifying the risks, and knowing why it matters. So we're happy to introduce our first speaker today, Despina Kayichian, who is a nephrologist and a former chief medical officer at the Venice Family Clinic. She's obviously spent a fellowship at one of our colleague UCs in nephrology, which is an extremely important area for that. And we're happy to have her present today. She is formerly, as I said, the chief medical officer for the Venice Family Clinic. So she sees a lot of patients with kidney disease and has the ability to start screening early in that population. At this point, she has stepped down, but she also relishes the joy of family life with being a grandmother and in the process of forming a nonprofit organization, which is called the Hummingbird Project, which is aimed at connecting school children of different ages with underserved communities to help or ensure early approach to those individuals. If we can teach our kids to consider the importance of health and monitoring their health and doing lifestyle practices that are conducive to long life, then we'll have an improvement. So we're delighted to introduce Despina Kayichian, who will discuss chronic kidney disease, how to screen for it, and when to start.
Thank you so much, Dr. Baumer, for this gracious introduction. Good afternoon, everyone. It is good to be with you all. I'd like to thank the Right Care Initiative team for inviting me to speak today. It is an honor to be with such esteemed colleagues and speakers, so thank you. The topic is CKD and screening, identifying the risk and knowing why it matters. I have nothing to disclose. The objectives of the talk are to identify what chronic kidney disease screening entails, identify population at risk for CKD, review recent changes in eGFR equation, and provide an overview of strategies to delay CKD progression to end-stage kidney disease. To screen or not to screen. CKD screening made news a few months ago, if you heard, when the US Preventive Services Task Force agreed to add it to the list of preventive services under active consideration. And this was at the request of the Coalition for Kidney Health, a multi-stakeholder group. Although the task force did not give a timeline, and we really do not know if the screening recommendation will happen this year, nevertheless, the nephrology community is excited that this step is even being considered. This is because 10 years ago, this request, although not exactly the same, was declined by the task force. In 2012, the task force said no to population-based screening. So what's being asked now is screening individuals at risk for CKD. So making the case for targeted screening was eloquently made by the American Society of Nephrology President, Dr. Susan Ivey, in this piece of Kidney News. Kidney News is a news magazine published by the ASN, the American Society of Nephrology. So why we should screen for CKD? It's because the incidence of chronic kidney disease and end-stage kidney disease have increased significantly the last 2 decades. ESKD cases increased by 42% in the period between the year 2000 and 2019. We should screen because awareness of CKD is low. Only 1 out of 10 patients with CKD know they have the disease. I was frankly shocked when I first learned the statistics not too long ago. 1 in 3 Americans are at risk for CKD, and 1 in 7 Americans have the disease. We should screen because in 2022, eliminating racial disparities in healthcare is a moral imperative, and we all need to combat systemic racism at every level. And we know that the burden of CKD falls on the socially disadvantaged and vulnerable, and those patients should be screened early. And finally, screening is important because CKD progression has become increasingly modifiable. Some more kidney disease stats. In the US, 37 million adults live with CKD and 785,000 live with end-stage kidney disease. Out of those, 230,000 live with a transplant. People of Black or African American, Hispanic or Latino, American Indian or Alaska Native, Asian American, Native Hawaiian, or other Pacific Islander descent are at increased risk of developing CKD. Black or African Americans are almost 4 times more likely than white Americans to have kidney failure. Hispanics are 1.3 times more likely than non-Hispanics to have kidney failure. This slide represents data from NHANES between 2015 and 2018, and this is the latest statistics published on the CDC website. The bar graph on the left is the percentage of US adults age 18 or older diagnosed with CKD based on age, sex, race, and ethnicity. As you see, non-Hispanic Blacks have the highest percentage of CKD. And not surprisingly, people older than 65 carry the heaviest burden. The graph on the right represents the number of patients with CKD and diabetes who are prescribed ACE inhibitors or ARB. You see the significant care gaps, especially when we're talking about a therapy proving to delay CKD progression and available to us for over 2 decades now. The percentage of patients with diabetes who were given ACE or ARB has varied in the literature depending on the population studied, but the percentage really continues to be less than 40%, less than 50%, between 25 and 40%. So pretty sad numbers. And then there's COVID. This slide is from the May 2022 issue of MMWR. It also reminds us that the burden that the pandemic really inflicted on chronic disease and on the healthcare in general. Data from electronic health records were compiled from March 2020 and November 2021, and they found that 1 in 5 adults age 18 or older have a health condition that might be related to their previous COVID-19 illness. And as you see, kidney failure is one of those chronic illnesses. So we said we're recommending to screen a population at risk for CKD. So who is this population? Who are those patients? Patients with diabetes, hypertension, cardiovascular disease are at the highest risk to develop CKD, and they should be screened. The rest of the slide is all the clinical condition in the population that are at risk for CKD. I'll give you a moment to quickly look at it. What I haven't mentioned in this slide is any patients with history of acute kidney injury, AKI, is also at risk to develop CKD and should be screened. So I want to step back to the CKD definition, mainly to highlight and to remind us that CKD definition includes 2 elements, and it's not both together, it's one or the other. The first element, we all know the GFR stages with the 6 stages that you see on this table. And the second element is albuminuria, A1, A2, and A3. A2 represents albumin excretion rate of between 30 to 300 milligram per day. And this is what used to be called microalbuminuria. We don't call it that anymore. We say moderately increased albuminuria. A3 is the greater than 300 milligram a day of albumin excretion rate. And it represents what used to be called macroalbuminuria. And there's a subset of nephrotic syndrome in that stage. So a patient with normal GFR and creatinine greater than 300 milligram per day meets the definition of CKD. And this has implication that I will mention to you in a bit. So we're talking about screening. What are the screening tools? The screening tool can essentially are 2 tests. Test for GFR based on serum creatinine equation, and test for albumin based on urine albumin creatinine ratio. You see the unit and the ratio. The numerator is the urine albumin and the denominator urine creatinine. So the ratio is reported in milligram per gram. Some advocate that we should lump these 2 tests into kidney panel, and just having the clinicians order kidney panel increase the rate of screening. We know that for the last 2 decades at least, the American Diabetes Association, the nephrology community, and others have recommended that patients with diabetes would get, at that time it was called microalbuminuria check, especially if the urine protein dipstick is negative. So how have we done over the last 2 decades with this measure? Sadly, as you see, even for highly insured patient, Medicare and privately insured patient, less than 50% of patients with diabetes in those populations were tested for UACR. So this is why the National Kidney Foundation and the MsHCA recently collaborated, and they added screening for kidney health in adults with diabetes as a new HEDIS measure that will take effect. The measurement here is this year. So the hope is that this measure will identify patients with diabetes and CKD at an earlier stage and decrease the burden of CKD, of end-stage kidney disease. This exactly going what Dr. Balmer was saying earlier, that measure and see how we perform on it. So let's dig deeper into the UACR. I'd like to start by saying that albuminuria, independent of GFR, is associated with increased risk of mortality, CKD progression, and end-stage kidney disease. The higher the albuminuria level, the higher this risk. UACR is performed on an untimed urine sample. It is better and best if it's done the first urine of the morning, but it is not practical. So any time of the day, it's okay to get the sample. At least 2 specimens over 3 to 6 months period is recommended before we implement a therapeutic intervention. Albuminuria is affected by non-renal conditions such as vigorous exercise, acute illness, especially febrile illness, congestive heart failure, and other conditions. Therefore, in the outpatient setting, we recommend we ask patients to avoid vigorous exercise for 24 hours before the test. So how do we interpret the number when we get them? Let's say you get a ratio of 300 milligram per gram. This suggests 300 milligrams of albumin excretion per day. The easiness of getting UACR makes the repeated value easy to obtain when treating to achieve goal, and I'll mention the goal in a bit. How about the GFR? Maybe 2 or 3 times a year, I have to remind myself, and at times I remind my colleagues what E and eGFR stands for. It stands for estimated. So this is not a perfect equation. Creatinine is not a perfect filtration marker. Creatinine can be secreted by the tubule. Creatinine production varies with the muscle mass and the protein intake, and creatinine can be metabolized outside the kidney. So it is important for us to remember when we base our clinical decisions on creatinine-based eGFR to know that these conditions that you see on the slide really represent a situation where the eGFR based on the creatinine is less accurate. So condition with extreme muscle mass, condition with extreme protein intake, very high protein or very low protein intake, a vegetarian who's not careful in making sure they meet their protein intake daily also could be in that category. Children, patients with cirrhosis, patient with amputation, patient with neuromuscular disease also have this creatinine-based GFR less accurate in the GFR estimation. So for example, a patient with cirrhosis who has a creatinine of 1, sadly probably lost 50% of his kidney function because those patients have very little muscle mass, they have a lot of wasting, and the creatinine normally is seen around 0.4 to 0.5 milligram per deciliter. So 1 is really double, and therefore 50% loss of GFR. So something to remember. So 2021 CKD epicreatinine equation is what is now recommended to measure the glomerular filtration rate. This was the work of a task force from the American Society of Nephrology and National Kidney Foundation, who were tasked to look at systemic racism in nephrology. And they came with a recommendation that race should be removed from the serum creatinine equation. We now know that race is a social and not a biological construct. And unfortunately, including race in the GFR equation has resulted in African American and Black patients' CKD being underdiagnosed and therefore not managed. I'd like to mention that the new equation is modestly less accurate than the 2012 CKD epicreatinine equation that has the race. It slightly underestimates the GFR in Black individual and slightly overestimate the GFR in other individual. But on a population level, it performs well, and the task force recommended we use it going forward. So in those clinical situation and condition where the creatinine-based equation is less accurate. The recommendation is to use the creatinine cystatin C equation to confirm what is the true GFR is. I'll mention to you actually a recent patient I saw last week. A 35-year-old man who has no chronic illness was referred to me to evaluate mildly increased creatinine and mildly decreased GFR. The patient was so distraught and super anxious because he's going to be labeled as CKD patient. He knew the implication. He had no family history, did not take any chronic NSAID, did not take any chronic PPIs, no herbal supplement, nothing to be concerned about when it comes to nephrotoxic medication or herbal supplement. And his UA was pretty benign, no albuminuria, no hematuria. So in this patient, and I should say also his exam was negative, no edema and no abdominal bruit and nothing. The exam was normal. And in this situation, I did need to confirm the GFR based on this creatinine cystatin C equation I sent for it. This slide is one of the most important slides in the deck. This is a heat map that I took from the National Kidney Foundation website, but it's published originally by the KDICO CKD work group in 2013. KDICO stands for Kidney Disease Improving Global Outcome. This is an international nonprofit organization that is very highly respected in the nephrology community, and we lean on the practice guideline that they published for a decade now. So this heat map is derived from a meta-analysis in which approximately 1.5 million individuals were followed for a mean of 5 years. The colors represent the risk for CKD progression, mortality, and morbidity. This is a sobering heat map for many reasons. Number one, on the first line, you see that the albuminuria, even with normal GFR, is associated with increased risk of mortality, morbidity, and CKD progression, as I mentioned earlier. It also shows that CKD patients are at increased, extremely high risk of morbidity and mortality, as you see in the red color and the dark red colors. And we learned behind this heat map that this mortality and morbidity is due to cardiovascular disease. So CKD patients are more likely to die of cardiovascular disease than they are to progress to kidney failure. It's pretty sad to know that only 10% of patients with diabetic kidney disease will reach end-stage kidney disease. So this highlights the importance of managing CVD risk factor in patients with CKD. And this is why we consider CKD as a coronary equivalent. And this is essentially what Dr. Balmer was talking about earlier as well. So while we should screen is becoming clearer right now, to increase awareness and increase the number of patients with CKD with or without diabetes, prescribed RAS blockade and other new therapeutic agents that I will mention in a bit. It's because diagnosing CKD should change the management. And I'll give you a couple examples. One of them, Dr. Balmer actually just mentioned as well. The ACC/AHA guidelines for the treatment of hypertension recommend a blood pressure of less than 130/80 in individuals with CKD. Also, the guideline for the management of lipids for the prevention of cardiovascular disease recommend moderate dose statin medication for adults with CKD, not on dialysis, and who are older than 50. So kidney disease is a risk factor for cardiovascular disease. Therefore, it is imperative that this disease is recognized, because it's not about just treating and delaying progression of CKD, but also implementing therapy for cardiovascular disease prevention. As you all know, CKD has no symptoms usually, and unless patients are screened, they may never be diagnosed or treated. I should say. So we, on this slide, the only point that I haven't made yet regarding the so what of CKD screening is CKD screening is important because we need to adjust medication dosing and avoid nephrotoxic ones such as NSAID and some argue PPIs. I cannot tell you how many times my CKD patients are prescribed high dose non-steroidal for acute pain, understandably so. They're very good to treat acute pain. But when the patient has CKD, and with no knowledge that this prescription will be detrimental to the patient's CKD progression. Sadly, this is frequently done by dentists at the clinic where I work. We have a dental clinic, but unfortunately, there's no interoperability between our EMR and EDR. So when they prescribe, when they see patient, they don't see that this patient has elevated creatinine. Definitely something we need to work on at the clinic. Another class of medication that I tend to avoid long-term are PPIs. PPIs have been shown to induce acute kidney injury and specifically allergic interstitial nephritis in patients, and they may be also the cause of CKD and end-stage kidney disease. So I try to avoid these medication PPI class in my CKD patient long-term. We'll spend a couple minutes on the slide to expand on those new and exciting tools we have to delay CKD progression. For the longest time, it felt, frankly, that the CKD, the nephrology in general, but the CKD field in particular is very stagnant. We've had only RAS blockade to delay CKD progression, so we really didn't have any tool to help our patient. And I always felt jealous of our, excuse me, I didn't realize my phone is connected, my earpod I connected to my phone. So at any rate, it is exciting because we have now 3 new medications that can delay progression of CKD. This picture is also taken from Dr. Quaggan's article and provide a helpful timeline for the new agents available for our CKD patient. The story, the happy story, started in 2015 with the EMPA-REG study. And EMPA-REG was a study looking at empagliflozin and cardiovascular outcomes. To everyone's surprise, and frankly, a finding that transformed the field of CKD, diabetic kidney disease, and CHF, empagliflozin not only improved cardiac outcomes, but also improved renal outcomes. Then came Credence, then came DAPA-CKD, and essentially those are 2 primary renal outcome studies. And this led to the FDA approving in April 2021 dapagliflozin as the first renal targeted medication. Dapagliflozin can be used now for CKD with and without diabetes. In 2021, Fidelio study was published, and in Fidelio, a new class, selective nonsteroidal mineralocorticoid receptor antagonist called finerenone, was added to RAS blockade and also showed improved renal and cardiac outcome. What I haven't mentioned yet is the effect of GLP-1 receptor agonist. As you all know, the American Diabetes Association recommend adding GLP-1 receptor agonist in CKD in patients with CKD and diabetes when either SGLT2 inhibitors cannot be used, let's say the GFR is very low, or when an additional agent is needed to improve the glycemic control. So we have a patient on metformin, SGLT2 inhibitor, will add GLP-1 receptor agonist when patients have CKD and diabetes. So all 3 classes of agent have been shown to improve not only cardiac outcome, but renal outcome. And it's very exciting to have them as new agent in 2022. I'd like to spend just a minute or 2 on the management of CKD, and I have 2 slides about that. Although I'm talking about screening, but since I have you as a captive audience, I thought I'll take this opportunity. And most importantly, because management of CKD, especially CKD3, is in your hands. So at the clinic where I practice, we see 27,000 patients a year. So as a nephrologist, I know that the majority of CKD3 patients are managed by primary care clinicians. So I talked to him about this checklist. Hypertension and sodium restriction. Those are the 2 interventions that I spend a majority of my time when I see patients with CKD on. 80%, over 80% of patients with CKD have hypertension. And hypertension in CKD patient is volume related. So CKD patients are salt sensitive. Even when they don't have edema, patients with CKD and hypertension would benefit from adding either long-acting thiazide or loop diuretic as a mean to improve their hypervolemia, like I said, whether occult or not. As I mentioned earlier, the goal for CKD patient hypertension is less than 130/80. But I put here in parentheses the home blood pressure. So home blood pressure goals always have to be lower than clinic blood pressure. We assume patients are more relaxed at home. But I also want to mention to you that we at the clinic provide our patient with a free blood pressure machines, because we all know that home blood pressure numbers correlate better with clinical outcomes than clinic numbers. So we encourage our patient to check their blood pressure at home, and that is a type of self-management, and that'll keep them engaged. We all know now that ARB, ACE inhibitors or ARB, and not both, either one or the other, should be used for proteinuric CKD. But I will mention that if you have a CKD patient without albuminuria or proteinuria, ACE or ARB do not offer any advantage over other hypertensive agents. They're great hypertensive agents, but they don't necessarily work better in decreasing CKD progression. So they are more effective in proteinuric CKD. And I mentioned already about SGLT2 inhibitors. Now, dapagliflozin is approved for a proteinuric CKD patient and other agents for proteinuric CKD and diabetes. So by now, I think I don't need to tell you why CKD patients should be on statin. We use atorvastatin and fluvastatin because they're not renally excreted. Smoking is contribute to CKD progression. So smoking cessation is one of the interventions to delay CKD progression. I wanted to do a temp check. I'll quickly mention protein restriction because it appears that Dr. Google still has it on the measure to decrease CKD progression, but in reality, in the era of ACE and ARB, and also era of SGLT2 inhibitors and other agents now, it is unclear how much protein restriction really will offer benefit to CKD progression. But there's also another factor. I find it extremely difficult. Any data restriction is very difficult to maintain. I mean, I know from my mom and dad, every time I go and eat at their house, their food is so salty and they both have hypertension, right? So our patients struggle with data restriction and struggle to maintain them. And if I want to choose one data restriction, I would choose salt restriction. But also my patients tend to have problem with high potassium. And if a patient has diabetes, they also have to do restriction of concentrated sweet, etc. And they are on statins, so it's the lipid that they need to worry about. So then if you have a patient and you're adding, who was doing all these restrictions, adding protein restriction on top of all that, it's not going to happen. It's going to make them very frustrated. So I rarely resort to protein restriction. And the final point I want to make is that CKD patients should be vaccinated with Hep B, but as you know now, all adults aged 19 to 59, it is recommended they get the vaccine, but CKD patients are at risk regardless of age. A quick word about albuminuria and proteinuria. We already know that they portend poor not only renal prognosis, but cardiac prognosis. And a reminder to use either ACE or ARB, ACE inhibitors or ARB, and not both. There is a goal, the lower, the better. We like to aim for less than 1 gram a day of proteinuria, but if the patient spills 10 grams of protein a day, we aim to decrease by at least 50%. So this is a great checklist. I use it, I try to keep it in mind, but frankly, when I see patients at Venice Family Clinic, I find it to be completely obsolete at times. So at the clinic, as I mentioned, we serve low-income patients, and 64% of our patients at the clinic live below the federal poverty line. So again, I spend a lot of time talking about hypertension and sodium restriction, right? So when I Oh, and I'll mention here that also we have approximately 4,300 patients who lack housing. So therefore, when I'm seeing a new patient, I need to say, I start by saying, do you have a stable place to live? And they say yes. I said, are you living with someone or you have your own place? And they say, okay, I have my own place. I said, great. And then I ask, can you cook? Can you make your own meal? And often it's like, no, I only have a microwave. So then it becomes more and more challenging for those patients to implement sodium restrictions. So we have to, adjust to what we have. Just recently, I saw a patient who was referred to me for possible polycystic kidney disease. And PKD is a condition where hypertension control has to be even stricter than 130, less than 130 over 80. And I'm asking the housing question. He goes, yeah, he was very happy that he was housed now for a few months. And I said, great. Are you able to make your own food? He goes, no, not yet. I still go to the shelter where I used to be and I eat 4 to 5 times a week. So you can see that salt restriction in this patient is impossible. So I try to choose. So I say, okay, if you're gonna get a hamburger, don't get the French fries. If you wanna eat French fries, don't add salt to it. So you just do your best. But often I have to say, at the end of the day, I feel a little bit defeated. I feel that my patient didn't need to come and see me at the clinic, didn't need my medication. They just needed to get a more robust social structure. So then I read an article like that and I feel hope again. So there's hope in a program that I learned about not too long ago, but has been happening across the country for decades. So this is an article published also in Kidney News and in June 2022 issue. So Special Diabetes Program for Indian was approved by Congress in 1997. It is rooted in population health approach and community-driven focus. It was implemented in more than 300 American Indian and Alaska Native communities in 35 states. The beauty about it is that the local tribes and community members have a leading role in not only implementing the program, but also customizing it to their need and the need of their community and to their culture as well. So clinicians in that program are not alone. They have the community to partner with, including pharmacists, nutritionists, care coordinators, and community health workers. The outcomes are phenomenal and a lesson for all of us to learn. So as you see here on this slide, cases of ESKD among American Indian and Alaska Native people increased for about 25% compared to 42% increase in cases in the US overall. The funding for the program was recently extended for an additional 3 years, and let's hope it will keep going for decades to come. On this uplifting low note, I'm going to close. And before I open the floor for question, I do want to apologize for the interruption of the phone. My dad was admitted last night with COVID to the hospital, and it was my brother calling me, and I thought I had my phone on silent, but it turned out that I had my AirPods, so it was connected to my phone. So my apology about that. So thank you for your time.
Well, thank you very much for that great presentation, and we'll have a couple of questions that we'll look at. One of the nice things about treating kidney disease and heart disease, in most cases, as you alluded to, the medicines that are protective for the heart are also protective for the kidney in most situations. So we don't really have a dilemma where if we're giving something that's good for the heart but not for the kidney, with the exception of this case that we see a lot, and that is individuals who have advanced kidney failure but need something done with their heart, typically a procedure that requires for us contrast. And we're literally afraid of contrast-induced nephropathy and sitting there and saying, the last thing I want to do is put this patient on dialysis, yet they're having chest pain or symptoms that require us to do a diagnostic procedure. And we've looked at various ways of trying to protect that patient other than hydration in that individual. is there any therapy or medicine that would perhaps protect them from the contrast-induced nephropathy that we're always afraid of?
Yes, at the end of the day, hydration is really the key intervention. And I think it's important not to underestimate that, because when I was a CMO at a community hospital as well, and I looked at this issue in the hospital I was leading as a chief medical officer. The amount of hydration, the degree of hydration is not enough often. And as you know, that the hydration has been at times bicarb versus saline versus back to bicarb versus back to saline. So in my opinion, hydration, but adequate hydration before, a little bit before, for at least an hour before and a few hours later, remains the key intervention. But I also like to say that in advanced kidney disease, when doing coronary angio will, the kidneys will take a hit. I remind my patients, their families, that right now what's important is that we're saving your life, and the heart takes first place right now, and the kidneys need to take backstage. And even if they require dialysis, hopefully, if the baseline GFR is not advanced, hopefully they will bounce back. So I kind of give the heart first priority in situation where there's a significant compromise in need for coronary angio.
Great. Any questions from our panelists or participants?
I'd love for you to elaborate. We could maybe just take one last question. You mentioned that the very ubiquitously used medication, the proton pump inhibitor, has some relationship with this condition. So I'm wondering if you can talk about that, given how broadly it's used in our population.
Yeah, absolutely. It is widely used. So we know that PPI can, and this is proven, they have caused acute kidney injury, and a special cause of acute kidney injury is the allergic interstitial nephritis, and this is not a dose-related injury. So we know that. For the longest time, we also felt that chronic PPI therapy can contribute to CKD progression. Lately, though, there have been some rumbles in the background of this literature. People feel that, maybe the data behind, this conclusion were not as robust. So this is why I was a little bit, if you remember what I said about the CKD, I said May. But if you had asked me this question, Hattie, a year or two ago, I would have felt more certain about it. Right now, we're asking to have more data to confirm that PPI do lead to CKD and end-stage kidney disease. I would say it is, in my practice, what I tell my patient, it's best to be careful. And in my experience, I've been a nephrologist for, 26 years now. I have actually seen on many occasions kidney function improve when I took the patients off PPI.
Well, thank you very much for that great discussion. And certainly we need to add kidney function monitoring by both urine and blood tests. We support your submission to the preventative task force, because I think it is important to start early, especially since these poor patients, really many don't know, as you said, 90% don't know they have kidney disease, as they progressively develop worse failure at that time. And certainly if we can detect it early in those 90%, we can prevent it, hopefully. So thank you very much. Cindy is now going to introduce our next speaker.
Thank you very much.
I'm going to introduce I'm
Oh,
going to introduce Cindy in just a second and just say that she is one of our longest, most dedicated leaders, Dr. Cindy Jambroni at Memorial Care. Thank you for being with us, and thank you for highlighting the importance of these metrics. It was wonderful to hear Dr. Kayichian's amazing presentation. I learned so much. And the fact that there's a new HEDIS measure on this, it's wonderful. So with that, Cindy, take it away.
Thank you so much, Hattie. And it is my pleasure to introduce Dr. Ashby Wolfe. So Dr. Wolfe serves as the Chief Medical Officer for CMS region San Francisco, Seattle, and Denver. She's a board certified physician. And as I was reviewing her bio, she certainly has a large territory and lots of frequent flyer miles, I'm sure. Her primary focus is focusing in on quality improvement, survey operations, and she works with some of the contracted health plans and serves as the principal liaison to the clinical community. She received her medical degree from Stony Brook School of Medicine in New York. She did her residency at UC Davis, and she holds a Master's of Public Policy and a Master's of Public Health from UC Berkeley. She has a particular interest in improving the quality and equity of care for our underserved and low-income population. She's also a published author, and I personally am looking very much forward to an area where I spend a lot of my day, which is in the Medicare Advantage Star Ratings, and will provide an update for all of us. So thank you so much. And Dr. Wolfe, I'll turn it over to you.
Thank you so much. And it's a pleasure to be here with you all today. And I'm just thrilled to be able to share some information on a topic that is often the subject of much confusion. And so I'm really looking forward to this opportunity with you all today. I also want to thank my fellow speakers today. I think we're really covering areas of both clinical interest as well as social interest that really manifest themselves in our patient populations that we serve. And I'm delighted to be able to provide some additional context here to the Star Ratings program that should be helpful. So as was mentioned, I'm a family physician. I've been in practice a little over 10 years. And I also serve as the Regional Chief Medical Officer for our CMS offices in the West. I'm based in our San Francisco and Seattle offices, and I also support our Denver offices. But the information that I'm sharing today is universal for the CMS programs. And so you can apply this information in whatever location you find yourself in. As is typical for CMS, this is a public service, so this information is available to you to share. There are some evergreen links in the slideshow, and of course, we'll provide this to you as a handout if we haven't already. There's been no commercial influence of this presentation. This is all germane to the Centers for Medicare and Medicaid Services federal agency. But as things do change on a regular basis, I would just encourage you to keep the links and the websites that I'm going to refer to in the front of your mind, because this presentation over time as a slideshow will become out of date. So what we're going to talk about in the next 30 minutes or so are the Medicare Advantage Star Ratings programs. And specifically, for those of you who aren't as familiar, I am going to describe the basics of the Star Ratings program, but then dive into some of the key elements for this year, and then talk a little bit about how CMS envisions focusing on health equity and where there is opportunity in the Medicare Advantage program to move that conversation further. And we should have about 5 minutes for questions as I conclude. So to kick things off, the Star Ratings program, what is it? So this is a way that CMS actually evaluates health plans that contract with the Centers for Medicare and Medicaid Services to provide Medicare, the program Medicare, to people outside of what we call our original Medicare program. So we have the fee-for-service program that people sign up for. they can also sign up to get Medicare through a commercial plan. And that's where this Medicare.gov Plan Compare website really factors in. Every year, CMS publishes the ratings around our Medicare Advantage health plans so that we can tell the public who might be looking for Medicare coverage options what the quality of healthcare and drug services are available through each of these commercial plans that contract with us to provide Medicare benefits to our Medicare beneficiaries. And the star ratings, the intent of the program is really to promote quality improvement and to recognize clinicians that are contracted with these plans for demonstrating an increase in quality of care performance over a defined period of time. The star ratings also reflect the experience of our Medicare beneficiaries and ideally assist new beneficiaries in identifying the best plan for them should they want to participate in Medicare through the Medicare Advantage program. And of course, an important component of this effort is to provide not only Medicare beneficiaries, but also their family members with meaningful information about the quality and the cost of their coverage. And at any time during the year, folks can actually compare plans by star ratings by going to medicare.gov/plan-compare. You can type in your zip code, or if you are a Medicare beneficiary, you can actually log into your account and take a look at what's available. So what exactly are we talking about? So the Medicare Stars program is a rating system, and we base this rating system on a range of quality metrics, which consists of a series of measures that come from a variety of sources. So you heard our earlier speaker talking about HEDIS measures. That is one component of our quality metrics set. We also use the Consumer Assessment of Health Plan Providers and Systems, or CAHPS survey, as well as the Health Outcomes survey, as well as additional CMS data and independent audits from CMS contractors. And we provide, or we perform, a variety of statistical tests to ensure that the information that we provide publicly is both accurate and representative of the information that has been gathered in the background. So this year, Medicare Advantage with prescription drug coverage contracts are rated on a scale of up to 38 unique quality and structural measures. We also rate plans that have just the Medicare Advantage component and plans that have just the prescription drug or Part D component. And every year we conduct a comprehensive review of this data to make sure that the measures are accurate, as I mentioned. And as I mentioned, we look at a series of quality metrics, and then we weight the average of that metric to become the overall star rating. And more information, the technical details of all of this is available via the website that's linked here. You can also email our star ratings team directly via this email box. Now, the star ratings has some important implications for the health plans that contract with CMS. Number one, the overall star rating is what's displayed on Medicare.gov, on the website that I just referred to. So publicly, plans are identified as being rated up to 5 stars, which is the highest rating that you can get. As a result of the Affordable Care Act, health plans are actually eligible for financial ramifications based on their star rating. So for plans who have a rating of 4 or more stars, they actually are eligible for a bonus payment from CMS if they achieve that rating of 4 or more stars. Consequently, plans who have ratings of 3 or fewer than 3 stars will actually be flagged for further monitoring and may in fact have their contract terminated with CMS if they are consistent low performers. So there's a real incentive here for plans not only to publicly identify their ability to provide quality care, but also there are financial ramifications to plans should they not be performing to standard. Another way that we flag performance in our system is through identifying these high-performing and low-performing plans with special icons. So for those commercial plans that contract with us in the Medicare Advantage program, if they receive an overall rating of 5 stars, they get highlighted on Medicare.gov as a 5-star plan. In addition, as I mentioned, for this year, 2022, there are a total of 87 contracts in Medicare Advantage that are highlighted with this 5-star rating. Now, as I mentioned, there's also the ramification of low-performing plans. And for those plans that are rated less than 3 stars for the last 3 years in a row that they have ratings, they get a low-performing icon on Medicare.gov. And there are additional ramifications if you're a low-performing plan, where beneficiaries may not enroll in the plan online. The beneficiary actually has to contact the plan directly. So rather than for the ease of being able to enroll online through our system, low-performing plans have an additional barrier to reaching beneficiaries as a result of their poor performance. We also send notices to beneficiaries if they have a plan with one of these low-performing plans, explaining that they are enrolled in a low-performing plan and they actually have a special opportunity to enroll in a higher quality plan should they choose to do so. So again, lots of consequences to plans who are poor performers in all of our metrics that we rate overall in the Star Ratings program. For the year 2022, however, there are no contracted plans in Medicare Advantage that have this low star rating. Last year, 2021, we did have one plan that received this warning, but this year there are no plans that are in this category. And this is what it looks like if you go on Medicare.gov and put in your zip code and take a look at what plans are out there. You can search and compare up to 3 plans at a time. And I just kind of randomly entered the San Francisco zip code, and this is what we got. So you can see there's the overall star rating in the first row of this series of columns. I've circled the overall star rating here. You can compare Anthem to Cal Plus to the Kaiser Permanente Senior Advantage. And you can see this is an example where a plan received the 5-star rating. So they get flagged with this 5-star icon. If you wanted to see more about the star ratings, you can click on the plan details button, and every plan has one. And you can see it's circled here in the middle column for Cal Plus. You could click there on the plan details, and we're going to get to that in a minute. But again, this is designed to help folks compare the overall quality of the plan, and then there's additional cost information that follows. So this is what you would see if you clicked on the plan details to see all of the star ratings. And there are a number of different categories in star ratings that dive into how the plan is actually performing in a variety of areas. So you can see there is the overall star rating, but then there are subsequent star ratings that also factor in things related to preventive care. So screenings, vaccinations, how good is the plan at managing long-term care conditions? What's the member experience with the health plan? Any complaints, and how does the plan handle complaints? And what's their customer service like? So again, each individual area of these measures has its own star rating, and all of the star ratings are weighted into this overall star rating, which is posted in clear view on the Medicare.gov website. So given that this is the University of Best Practices and we're talking about cardiovascular and kidney health today, I wanted to flag a few of our measures as illustrations of how the star ratings highlight how well a plan does and how well its clinicians do in managing some of these chronic conditions. So again, this is all public information, and should someone be so motivated, they can click down into the star ratings to look more closely at how a plan is rated for managing long-term or chronic conditions. And let's say you're a Medicare beneficiary who has chronic kidney disease. You could click on these star ratings and take a look and see, how does this plan manage when it comes to kidney function testing? And about halfway down this slide, you can see there's a measure that speaks to kidney function testing for members with diabetes. And this plan gets 5 stars for that work. Now, there's a lot behind this measure, and specifically, this does not tell you, if you're a clinician, it does not tell you what that kidney function testing is. Does it mean that the plan is simply ensuring that the patient is getting their creatinine and GFR checks? Does it mean that they're doing the urine testing that our previous speaker spoke to? No, that level of detail is not provided in the star rating. This information is really designed for quick glance by the Medicare beneficiary themselves. Of course, we encourage beneficiaries who have questions about the meanings of these measures to follow up with the health plan itself. But again, you can see that this is pretty useful for someone who may not have clinical background, but who may have chronic conditions. So not only are plans rated on their ability to provide ongoing monitoring of kidney function for patients with diabetes, but we are also rating the plans on their ability to monitor patients with diabetes when it comes to blood sugar control. We also look at issues related to medication reconciliation, eye exams for patients with diabetes, etc. And of course, as I mentioned, member experience is another aspect of the star ratings for which a plan gets rated. And again, the overall member experience with this health plan is 4 stars. And you can see at the breakdown here, things related to customer service, like the ease of getting care, accessibility, does the health plan provide information or help when members need it, and what is the patient's actual rating of their health plan if they were to give a rating themselves. So in summary, Medicare Advantage and Part D star ratings are really designed to help Medicare beneficiaries and their family members compare the quality of care that is being provided in Medicare Advantage and Part D drug plans. And again, that's really the design of the star rating system. And just to remind folks again, when it comes to star ratings, we're looking at high-performing plans as well as low-performing plans, and there are consequences to falling into some of those categories. And while we do make adjustments every year in the way that the data manifests in the star rating, and in particular for this year, there are some adjustments related to the implications of the COVID-19 pandemic, the measures really do reflect the ongoing efforts at the plan level and at the clinician level for doing that continuous quality improvement that we are all engaged in one way or another. So now let's talk about some of the details of what Medicare Advantage and the Star Ratings program looks like across the country. And if you compare last year to this year, access to Medicare Advantage plans does remain relatively stable and strong, although there are areas of the country that have limited or no access to a Medicare Advantage plan. And those spots of the country are represented by the yellow on this map. So you can see parts of the West in particular where there are no available Medicare Advantage plans. In those communities, the option, if someone is eligible for Medicare, is to have Original Medicare, which is our fee-for-service program. We do continue to see enrollment slowly growing over time, and benefit offerings in the Medicare Advantage space are increasing. And we're going to talk a little bit about what that means in the next couple of slides. But this year, there are over 450 more Medicare Advantage plans that are operating in the country compared to last year. And we have had enrollment increase by about 10%. So that's an all-time high of 29.5 million Medicare beneficiaries who are actually in contracted health plans through our Medicare Advantage plan. So this is what the star ratings actually look like in terms of overall star ratings. And you can find not only this chart, but a lot more detail via the link on the bottom of the slide, which is going to take you directly to our 2022 star ratings fact sheet. So a couple of points about this chart, which is rather busy. I think the bottom line for folks to take away is that overall, in the star ratings program, we see that there are higher star ratings for plans that have more experience in the Medicare Advantage program. So for commercial health plans that are newly contracted with CMS, they're less likely to obtain that high 5-star rating than a plan that has been in the program for several years. And a lot of that has to do with the experience of managing the Medicare Advantage beneficiary patient population and the ability to coordinate continuous quality improvement when it comes to the measures that are part of the star ratings. But overall, this is the star ratings comparing several years previous to 2022, which is on the far right-hand side. And overall, we have about 68% of our Medicare Advantage combined Part D program contracts. That's 322 plans that have 4 stars or higher in the program itself. So that's a pretty significant number of contracts that we have with 4 stars or above. Similarly, we also rate the Part D plans. This is just separate from the other portions of Medicare Advantage. And like the Medicare Advantage plan counterparts, we have a majority of prescription drug plans that received 4 or more stars. We have 54% of these plans, or 29 contracts in the program, that have 4 or more stars based on their 2022 star rating. And again, just like with the previous slide, Part D plans who have been participating in Medicare Advantage for longer periods of time tend to have higher star ratings. So there is what looks to be a learning curve in the star ratings program, again, associated with management of the patient population, as well as ensuring that the plan is responding to those quality metric indicators that I've described. And again, when it comes to the impact of a star rating, it's pretty significant. That star rating is published for people to look at on Medicare.gov. 5-star plans do have, 5-star and 4-star plans have a financial benefit to achieving that rating in that they get an increased bonus payment from the federal government. And of course, if you're a low performing plan with fewer than 3 stars, we flag you as such on Medicare.gov. And if you have that low performance for 3 years, you are taken off of online enrollment, and there are enrollment, we disable enrollment for beneficiaries through the online process. So there's some real consequences for not achieving 3 or more stars in the program. These are the measures that we're talking about, and this is a very busy slide, so I really just put it up for illustration. You can actually take a look at this chart as well as other charts and references via the link on the bottom of the slide here, which again will take you to a fact sheet, which is actually a fact packet about the 2022 star ratings. But overall, these are the measures that we're talking about. And again, a lot more described here in the fact sheet itself. But again, we're looking at issues related to diabetes care, eye exams, kidney disease monitoring, blood sugar control. We're looking at annual flu vaccines. We're looking at the provision of a statin for those whom it is appropriate, various preventive screening measures, as well as overall ratings of care coordination. So again, you can see this is comparing plans in their 2019 star rating overall compared to the 2022 average star ratings. And in general, we are slowly seeing trends where the plans are achieving better star ratings over time. This is a different representation of similar data where we're looking at the plan's performance compared to a previous year. And overall, encouraging information about some of our measures where statin therapy for patients with cardiovascular disease, for example, has seen an overall increase in performance across plans compared to last year. We have seen some decreases in performance around diabetes care, however, and in particular, when it comes to kidney disease monitoring. So this is another way that CMS watches how plans are doing over time and identifies particular potential interventions for plans that are poor performers. And again, you can take a look at this chart in much more detail on the fact sheet that's linked at the bottom of the slide. Now, I did mention that there are some additional benefits that Medicare Advantage plans can provide, or they have the option to provide, that go beyond the original Medicare offerings that we have in our fee-for-service program. One of those additional benefits is in telehealth, where Medicare Advantage plans are allowed to provide additional telehealth benefits beyond what is allowed under the original Medicare program. And plans can actually treat those as basic benefits for the purpose of their bid when they contract with CMS. The exciting thing behind that is that about 96% of beneficiaries with Medicare Advantage are actually able to take advantage of some of these telehealth benefits, and that includes engaging with their primary care clinician, access to mental health and specialty psychiatric services through telehealth, in addition to the face-to-face in-person visits that have traditionally been more common, although COVID has really allowed for opportunity in the expansion of the telehealth space across many different coverage programs. In addition, in Medicare Advantage, there has been an expansion of what we call supplemental benefits. These are benefits that are health related, but are actually often related as well to the person's functional status. And we'll talk a little bit about that on this slide here, where CMS actually expanded the definition of what we call health-related supplemental benefits, such that now about 1,000 of our Medicare Advantage plans nationwide are providing these expanded benefits, which includes coverage for some adult day health services, home-based services, and caregiver support, which starts to address some of the challenges that were spoken to earlier when it comes to the social determinants of health, which often have significant impact on the health outcomes of our patients with chronic disease. We also have a program through Medicare Advantage to allow plans to offer benefits at reduced cost sharing, specifically for those with diabetes and congestive heart failure. So if you are a Medicare Advantage beneficiary and you have diabetes, for example, you can potentially access benefits at a lower cost as a result of your chronic condition. And finally, we have additional supplementary benefits for what we call the chronically ill population. We define that chronically ill population as having one or more medically complex chronic conditions that is either life-threatening or significantly limits the overall health or function of that person, leading to a high risk of hospitalization or adverse health outcomes. And obviously in that category, it is likely that your care requires significant care coordination. And if a beneficiary in Medicare Advantage falls into this category, there are supplemental benefits that the plan can provide that don't necessarily have to be directly related to your health, and specifically can address directly some of those social risk factors that we've been talking about in both the previous presentation and my own. So you can see here in 2022, in the Medicare Advantage program, there are more than 1,300 Medicare Advantage plans that will offer this benefit to select members of their plan to provide coverage for food and produce meal delivery transportation and some home environmental services, which can include things like providing grab bars, removal of risks for falls and trip hazards, and things of that nature. So there's sort of an expanded supplementary coverage opportunity in Medicare Advantage, which does not exist in original Medicare. Now, all of this is to say there is a strategy behind this from the CMS perspective, and that's really articulated within the republished National Quality Strategy, which came out in April of this year, really emphasizing CMS's focus on quality improvement across all of our programs in connection with a focus on health equity. And there are 8 quality strategy goals that the agency uses to enumerate its approach here. I don't have time to go into them all during this presentation, but I would like to focus on, in particular, this area of advancing health equity. And that's articulated also in our strategic pillars, which are used to support sort of the action items behind our national quality strategy. So if you'd like to learn a little bit more in terms of what CMS has published on this approach, the links are available for you on the bottom of the slide. But I'm going to try in the last couple of minutes of my presentation to describe a little bit about how this focus on health equity is really starting to manifest itself in the Medicare Advantage space beyond the supplemental benefits that I was just describing. And we know that health equity can be defined in a number of different ways, but for CMS, we define health equity as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, and other factors that may affect access to care and health outcomes. And as I mentioned, this is really one of the foundational pillars of our national quality strategy, where we're looking to advance health equity across all of our programs in 3 specific ways that are defined on this slide. So the design, implementation, and operationalizing our policies and programs. So that includes not only Medicare Advantage, but work with our states in the Medicaid space, as well as our original Medicare fee-for-service program. We're looking at ways to avoid and eliminate differences in health outcomes that are experienced by people in disadvantaged or underserved communities across our programs. And we're looking to be able to provide the care and support through our programs that our enrollees need. So a lot more detail available via the link on the bottom of the slide, but CMS has also recently issued a framework for health equity, which really describes more specific action that CMS is looking to take. And that's highlighted here on this slide where you can start to see some of the connections to the work in the Star Ratings program and in Medicare Advantage, where one of our priorities is to expand the collection, reporting, and analysis of data that can potentially then be used to inform decision-making around CMS policies, which would, of course, include how we manage and oversee plans in the Medicare Advantage space. And of course, we're also looking at ways to assess the causes of disparities within CMS programs and then address those inequities. And I wanted to highlight priority number 2 in particular because of some of the recent work that CMS has done looking at the state of the world, as it were, within the Medicare Advantage program. Before I get to that, I do just want to briefly review the existing health equity goals that, again, kind of manifest themselves through the framework that I was just speaking to. But again, you can see the themes here are very similar in terms of incorporating screening for and promoting access to service for health-related social needs, adopting specific quality measures to assess the social risk of our patient populations, and coordinating with community-based organizations to really try to address some of those social determinants of health, which currently is manifesting itself in some ways in the Medicare Advantage program. Again, the 4th goal here on this slide, looking at ways that we can better collect and use data to understand what our beneficiary populations look like. And of course, ongoing work to evaluate what CMS programs look like right now so that we can better determine how to serve our communities, both our clinician community and our beneficiary community themselves. And this report is one manifestation of all of that rhetoric, if you will. This is a report that was issued in April that focused on what does the experience of our patient populations in the Medicare Advantage program really look like. And as I mentioned, this was released in April. You can get to this report via the link on the slide. And this report really details the racial, ethnic, and sex differences in healthcare experiences and in clinical care experience received by Medicare Advantage enrollees. This was a report that utilized a number of sources of data, including our HEDIS and CAHPS surveys, which, as you know, as I spoke to earlier, are quality measures that are also used in our Medicare Advantage program. And this report used data from those 2 surveys from 2021. So the hope is that this report can be useful to organizations like your own, healthcare professionals, researchers, et cetera, to not only raise awareness of existing challenges, but also to identify ways that there could be interventions developed to support improvement over time. And I've put a few of the key takeaways on this slide, but in particular, when looking across our racial and ethnic groups in Medicare Advantage, there were few differences in scores by sex on either patient experience or clinical care measures, but the analysis did find some important takeaways in that female multiracial Medicare Advantage enrollees tended to fare worse in the program than male multiracial Medicare Advantage enrollees on measures of patient experience. Male Black Medicare enrollees fared worse than their female counterparts on measures of clinical care. And so the key takeaway here, which is highlighted on the bottom of the slide, is that there are some efforts that are particularly needed to look at key indicators like increasing flu vaccination rates for our Black, Hispanic, and multiracial Medicare enrollees, Medicare Advantage enrollees, looking at improving the clinical care experience point blank for American Indian, Alaska Native, and particularly Black, male, and Hispanic Medicare Advantage enrollees, and improving the patient experience for our female multiracial Medicare Advantage enrollees. So some real key takeaways here that, again, CMS has published, but is also reviewing on an internal level as well to identify where there might be opportunities for quality improvement in the Medicare Advantage space. How that will manifest itself, I'm not quite sure yet, but you can bet that this is something that will continue to influence our discussions and our evaluations of the Star Ratings program over time. And my last slide is really focusing on how you all can continue to engage in this conversation with us, and recognizing that not only does the report I was just speaking to, but other indicators suggest that we still have a lot of work to do in not only the Medicare Advantage space, but across all our programs to advance health equity. CMS has actually requested public input on how we might improve the Medicare Advantage program. And we're really asking for public comment around how we might better develop a more equitable, high quality program. So we've actually posed a series of questions for public comment. That public comment is due by August 31st, and the way to comment on this opportunity is via the link on this slide. But again, we're really looking at the Medicare Advantage space in terms of expanding access, advancing equity, and looking at ways that we can further engage. And a couple of examples of the questions that we pose include: what steps should CMS take to better ensure that all Medicare enrollees receive the care that they need? What are effective approaches for screening, documenting, and furnishing health care that is informed by social risk or social determinants of health? How could CMS improve the Medicare Advantage Star Ratings measure set to more accurately reflect true quality of care? So we're really asking for input. And this is one of those opportunities where anyone can comment. You don't have to be a member of an organization to provide us your feedback. And we are required by law to read everyone's comments. So this is one of those unique opportunities where if you have questions about how Medicare Advantage is manifesting in a given population, this is the opportunity to give us your thoughts. And a comment can be something as simple as 1 or 2 sentences, or it can be something like a packet of research and other information. So we really take all comers, and really would be delighted for folks to take this as an opportunity to give us some feedback. That being said, that was my last slide. This is my contact information. And as always, if you have follow-up questions about either this or other things related to the Medicare, Medicaid, or Marketplace programs, this is how you can find me. So with that, I will stop sharing, and maybe we have time to take 1 or 2 questions before I introduce the next speaker.
Dr. Wolfe, yes, we actually have quite a few questions. But the first question I will ask is on the report that you mentioned that was published in April 2022, the disparities in healthcare. Is that a report that you can look at information based on your own region, or is that across all of CMS? Can you drill it down to your own neighborhood is what I'm really trying to ask.
Yes, that's a great question. And so the short answer is yes. There's lots to unpack in this report. It's a very long report, as you might imagine. CMS tends to issue lots of lengthy things. So I would encourage folks to take a look at it. We have a series of appendices and other data packets that are affiliated with this report for further research. And that was really part of the intent in issuing this report, was to make this information available for members of the health system community to further engage in this conversation. The report does offer some suggestions in terms of solutions, but we were really intentional in presenting the data to further the conversation and to not try to come up with blanket solutions on our own.
Perfect, perfect. Another question from the audience is, does CMS have plans to change star rating measures beyond being on a statin if you have ASCVD, such as having an LDL less than 70? Since many times being on a statin is the minimum standard, or should be?
That's a great question. And I think this is one of those situations where the star ratings are built on a series of measures that CMS does not own. So given our previous speaker and some of the information around how we all should be managing chronic kidney disease right now, that information has yet to manifest in the star ratings program. However, given that HEDIS is starting to incorporate some of that information, and given that the U.S. Preventive Services Task Force has now come out in favor of the other GFR equation, I think we're likely to see the star ratings measures related to kidney disease and cardiovascular disease adjust over time, but it doesn't happen instantaneously, and it's usually like a 3-year process for measures to go from recommendation from a clinical community to manifesting in the STARS program. That's certainly not ideal when we know that it can make a huge difference in the function and the lifestyle of a patient with cardiovascular disease or chronic kidney disease. So that's another, area that we're looking to engage with this request for information that I mentioned, is to hear from the experts across the country, how might we better improve the star ratings program to better reflect what's actually either clinically recommended or some of the newer evidence that's really starting to guide practice. How do we do a better job of making our star ratings program more responsive to that?
Thank you. And Hattie, do we have time for one more, or do we need to move forward? You're muted.
I think we should hear from Chairman Balmer, since he's had his hand up for a while.
Oh,
And
okay.
I wonder, I think these questions are great. I'm always willing to stay on as long as people need, but I know that Dr. Ivey has to pivot to something else at 2:05. So Bill, quickly you go, then we'll go to Dr. Ivey.
So I have a quick question. So it's certainly we want to thank you for that presentation of the STAR program, which it appears to focus a lot on what we would term measures of outcomes or measures of quality, et cetera. In California, we're also interested to go beyond measures. So for our higher risk individuals, in addition to looking at multiple measures which we monitor, we're very interested in what we would call outcomes. Outcomes would be number of heart attacks, strokes, and deaths, because our goal to get to zero is to reduce those. So knowing that CMS has unlimited resources, is it possible that CMS will advance from the measures you're looking at in the STAR program to actually include things that would be more outcomes or hard outcomes, which would be important to me as a referring doc? I think you should go to this program. They have the best rating for risk-adjusted outcomes. And if I send you there, I'm comfortable that that's a good referral.
It's an excellent question. The short answer is yes. The longer answer is that is the subject of a lot of discussion of how those more outcomes focused evaluations would manifest in the STAR ratings program. And not just outcomes when it comes to clinical outcomes, but actually looking at patient reported outcome measures as well. What's the outcome that the patient actually cares most about, and how would that manifest in a measure that we could then ascribe to a given plan? So would love to follow up on that conversation, because I think there's a lot to unpack there. But yes, the short answer is yes, CMS is not only looking at that, but starting to, in some of our other programs, starting to have those measures be a part of our reporting programs. And I think it's only a matter of time until we see that in the STAR ratings program. And with that, I believe I am introducing our next speaker. So I will go ahead and do that. It is my absolute pleasure to introduce Dr. Susan Ivey, who I know many of you know well. Dr. Ivey is a professor at Cal and has been the director of research at Health Research for Action for many, many years. That's how I got to know Dr. Susan Ivey. I was one of her graduate students back in the early 2000s. Memories. So it's wonderful to see Dr. Ivey again here today. She is an incredible expert in the area of health services research and has conducted research across many different topics, including focusing on low-income populations, immigrant populations, specifically with a focus on health disparities. She has published widely and also in her spare time teaches in the Berkeley UCSF Joint Medical Program. So without further ado, Dr. Ivey, over to you.
Thanks, Ashby. It's great to see you too and hear all of this new work that you're doing. Ginny, do you have our slides? Put those up. This is our graduate student right now, Edith Baca. She's an MPH candidate in our MPH program at UC Berkeley and a student researcher at our Health Research for Action Center. And she can say a little bit more about herself, but came to me as an undergrad from UC Santa Cruz, wanted to get involved in public health research, and plans now to continue her education post-MPH by pursuing a physician assistant degree upon completion. So thank you, Edith, for co-presenting with me today. So we're going to talk a little bit about some preliminary findings from our program that trains undergraduate research students as health coaches. Their focus is on promoting lifestyle change for people who have elevated blood pressures over 140/90. Next slide. We have no conflict of interest to disclose, and we have grant funding from the Jeffrey Thomas Stroke Shield Foundation to work on stroke prevention strategies. Next slide. So before we started, we looked at the evidence, wanted to look at any technologies that have been applied for high blood pressure. We knew that technology is advancing rapidly in the areas of apps and blood pressure devices. We looked at a few new blood pressure devices that were coming into vogue, and especially wanted to look at apps related to lifestyle changes. We could find from our literature review that there was more smartphone penetration, including among low-income groups, including Latinas. And so we felt like we could use a smartphone as part of the intervention. There was an increase in technology interventions, and we also knew a lot of venture funding was going into mHealth, which might mean there will be more devices to find. I think the promise of technologies in high blood pressure is primarily for promoting self-monitoring of blood pressure in the home, which has become a key recommendation of the American Heart Association and the American College of Cardiology. But digital innovations can also support record keeping, communication with the healthcare team around measurements taken remotely, including how to move data into the electronic health record, promoting better medication adherence, and facilitating lifestyle change or behavior modification for the kinds of evidence-based behavior changes we wanted to see. Next slide. Additionally, it showed that even though there were a lot of new devices, most of them hadn't been well tested, but we had good devices that had been well tested. The older upper arm blood pressure monitor and digital device technology was still ascendant, if you will, during that time. And we also knew low-tech interventions like telephone interventions, many other workers, pharmacists, pharmacy techs, community health workers, and health coaches had all demonstrated some effectiveness and better control of blood pressure. Telehealth increased dramatically, as you all know, during the COVID pandemic period. And that was also, I think, an impetus to allow reporting of remote blood pressures during televisits, which would mean that patients have to have their own blood pressure cuff at home. We also know that a lot of these devices have Bluetooth enabled transfer of data. We've had some problems with interoperability of data, but new standards HL7 and FHIR are, I think, going to help with interoperability. And additionally, we've had some right care presentations about UCSF working very hard to allow Bluetooth movement of blood pressure data into EPIC. So it's still not universal, but I think we've made some strides in the right direction. Medical devices can also be designated as substantially equivalent by the FDA. They're not really approved per se, but rather they review to see if they're validated and reliable in a way that allows the FDA to say they're substantially equivalent under the 510K substantially equivalent status. So we knew that our Omron upper arm cuff series, the Omron 5, which has Bluetooth enabling and has 2 memories, would be one that had this FDA status. We also knew that interventions that contain a mixture of modalities appear to be more efficacious than single modality interventions. And so we knew we would be integrating these digital devices with promotion of self-monitoring blood pressure at home by health coaching, helping patients set their goals with motivational interviewing. And it could also be combined with something like provider education to promote better uptake of evidence-based treatment strategies, although that is not included in our current intervention. Next slide. So the intervention design was to do a randomized controlled trial as a feasibility study. It's a small study, uses the blood pressure cuff for the upper arm, which has been shown to be more reliable and valid than the wrist monitors and the ring monitors, new things that have come out. It also would ensure a way for the data to move, because originally we were using American Heart Association's check change control portal, which allowed the coach and the participant to be in the same portal, and the participant could allow the coach to view their data. That portal has since been removed about a year and a half ago. So we created kind of our own tracker that's on a secure server where coaches can enter those blood pressures. The health coaches also use motivational interviewing to support lifestyle change, which we know has evidence basis that it can reduce blood pressure through better adherence to DASH diet, more physical activity, reduction in sodium intake, stress reduction, and smoking cessation. We wanted to add a little bit more in terms of goal setting, also by adding sleep. The coaches are all undergraduate UC Berkeley students who are trained to be health coaches, and they receive academic credit through our undergraduate research apprenticeship program. Initially, the intervention was based with a collaboration with a federally qualified health center in our area. But as we moved into the pandemic, they were no longer able to really have the time to work on this. So we then pivoted to do some work with a small hospital health system who welcomed us, as well as a lot more community recruitment, which Edith has done a really great job of doing that. So I'm going to let her speak to some of the student parts of the intervention now, and then I'll come back. Edith?
Thank you, Dr. Ivey, and thank you, Riker, for inviting me to speak today. So now let me talk about undergraduates and recruitment in our Spanish translation efforts. I want to start by sharing the expectations we had for all students in the study. All students were required to attend and participate during our biweekly all-team meetings. They presented the progress that they had done on the sub-project teams, discussed research articles previously assigned in a journal club format, and also reflected on coaching experiences. They were also required to participate in 1 to 2 sub-project teams, and I will cover more on the next slide. Depending on the student, they could coach 3 to 6 participants for the 9-month study. And lastly, they were required to complete city training online and any other coaching or research work assigned. And again, these students were enrolled, most of the students were enrolled in the undergraduate research apprenticeship program, which provided them with academic credit. Next slide, please. Before the pandemic, the original training included a semester-long curriculum with in-person weekly classes featuring HAA's Life Simple 7 discussions and guest speakers, and also motivational interviewing and blood pressure device trainings. But as after June of 2020, our curriculum was completed virtually. We had HAA pre-recorded lectures and readings to facilitate remote learning. And then we also provided the students with a BP cuff to practice with housemates or any other team member. We paired the student with the experienced health coach in a big and little style to ensure that all students had all the support they would need. And additionally, Morgan and the project coordinator and I had required and optional drop-in office hours throughout the week for us to cover secure server protocol with the students. Next slide, please. A few highlights of the curriculum are that we provided them with hypertension knowledge and with BP device trainings and on how to educate people on measuring their own blood pressure. We guided them through the 5 lifestyle change goals. We provided them with many opportunities to work in teams and lead and learn how to lead other team members as well. And also knowledge on the study processes, such as study design, research protocols, data privacy, use of consent, and analysis using R. Once the student was trained, Dr. Ivy, Morgan, and I would assess their competency level. And as part of my supervising role, I continuously reassess and supported the students with protocol and curriculum knowledge. Next slide, please. Here I have listed a couple of the sub-project teams, which again, allow the students to work in teams and learn how to lead their own projects with assigned tasks. Next, please. The types of supports we provided to the students included a one-on-one check-ins to support them through challenges they face in school or any other personal matters. We also provided them mentorship opportunities to learn more about careers or employment options. The students also had their bigs for additional support, which they contacted whenever they needed to. And we also had an end of the semester celebration where the students had time to unwind. And as well, the seniors graduating would receive a health coaching certificate, which was something they could take with them and feel proud at the end of the time of the study. Next, please. As you all know, the pandemic brought with it many challenges. We stopped recruitment and data collection, to which we pivoted to remote with IRB approval. All interactions with the participants were remote, and after October 2020, UC Berkeley allowed us to do outdoor in-person intakes with participants, of course, using PPE and safety precautions. Due to the slowdown in participant enrollment, recruitment practices just changed dramatically for us. Next, please. We communicated and created new partnership with student organizations and senior centers, among other community organizations in Berkeley and nearby locations. We also had our partnership through Washington Hospital in Fremont, which we used throughout 2021. And we had biweekly recruitment events within the community using eye-catching flyers with QR codes and tear-off tabs. And next, please. And the last topic that I will be discussing is our Spanish translation.
We've admitted there have been a total of 35 undergraduate students who were accepted to join the program. 89% of them were trained as coaches. 4 of the 35 assisted in the project as research assistants, and we've had 2 graduate students so far. In addition, we've given 5 oral roundtable or poster presentations at meetings like American Public Health Association, the UCSF Health Disparities Meeting, and the Consortium of Universities for Global Health Conferences. We've also submitted 6 other abstracts that we're waiting to hear about this year, and then an honors thesis that I'll talk about in a minute. So our team is about 8 coaches actively coaching. We've replaced coaches as have graduated and then trained new students to replace them. We also have a number of graduates who are still involved even after graduating that we're able to have as volunteers in what's called an affiliate status. Next slide. We also do some quality surveys just to sort of get a little bit of information back from participants about their satisfaction with health coaching. This is not part of the research, but rather just kind of helping us do quality improvement, engaging people's satisfaction. So looking at this sample to gauge Arm 1 participants are the only ones who get a health coach. And 89.7 said they were satisfied with their experience in the study. 89.7 satisfied with coach communication, and then a whopping almost 97% satisfied with their health coaches. So what that told me is that it's very feasible to train college students to do this activity, but it also does require monitoring. And again, as they move through school, you have to be able to add to the team and train new people to take their place. Next slide. We had a wonderful summer project last summer that was funded by the Summer Undergraduate Research Fund. David Pack, one of our former students, created and piloted an intervention, a Filipina cookbook that had healthy Filipino cooking, including interviewing Filipino and Filipina chefs, gathering in recipes, adapting those recipes, and working with a clinical dietitian to do nutrient analyses. Then we assessed the feasibility with a group of Filipino patients who had high blood pressure that were recruited from a local clinic. They created an amazing product with recipes in both English and Tagalog, and they're now fundraising to do a printing and distribute these to Filipino serving organizations in the Bay Area. As all of you probably know, Filipinos have one of the highest rates of high blood pressure of the Asian groups. Next slide. This was our public health honors thesis this year, predictors of blood pressure and blood pressure control behavior among adults with uncontrolled hypertension, by Brandon Kai. And he's now received his bachelor's in MCB and public health with a bioengineering major. So we're very happy about his success, and we'll be working on turning that into a manuscript. Next slide. So I just want to acknowledge our whole team. I've been just so impressed by the ability of these undergraduates to kind of stick with it. One of the things that I was told at the beginning is students wouldn't stay with the project, and we'd just be constantly changing students in and out. It was supposed to be a 2-year project. So the goal I set for myself was, can I keep students on board for 2 years? But now we've had some that have stayed for 3 years, and just been a really great experience. And look forward to hearing more community health worker outcomes in one of our later programs in September, I think. And just want to thank our Washington Township Medical Foundation friends for their support at Washington Hospital. That allowed us to continue during the pandemic, because we were at a hospital, the patients were already going through getting masked, doing gel on their hands, having temperatures taken, having COVID questions done. So by the time they got to the room where we were pretty sure that they were probably negative. And then we were all masked and gelled and everything too. And then Lifelong Medical Care for their quality improvement team that helped us a lot in the first year of the project, just unfortunately could not continue. And then our funder, Jeffrey Thomas Stroke Shield Foundation. So we're happy to answer any questions. I think, you know, again, there was a lot of skepticism at the beginning whether students could take this on, and they're clearly able to do it and have such enthusiasm that I think people really enjoy that coaching from their students. And this is our team this year, mask-free, having a picnic. So in between waves.
Just commend you for this remarkable work, Dr. Ivey. It's really heartwarming, and I feel like we should make it a requirement. But Dr. Bill Baumer has the first question. Go ahead, Bill.
Thank you for a great presentation and really great success. We've all looked at how we could use coaches and community health workers to improve our control of blood pressure and other risk factors. I'm curious, I assume the students are volunteering. Is there a way that you foresee scaling this up to where we could cover the state of California for this? Because, or does it require that there be a catchment area on a university where we can, in fact, entice these individuals for academic reasons to come in and get, let's say, student credit or something like that? So we would like to expand this across the state. Is it require us to jump on to every university or advanced schooling place in California to do that?
Well, at the beginning, I would have said it had to go campus by campus because we were in person and they needed a lot of, you know, hands-on learning how to do blood pressures. Motivational interviewing is not easy for those of you who do it. You know, you have to really practice and get good at it. And it's not just motivating people, it's like literally helping them set their goals and then supporting them, whether they fail or succeed. you're giving that support for them. So I think a lot of physicians aren't actually trained to do it, but also we don't have time to do it. It takes a lot of time. You know, we're not going to call people every week to check on how their blood pressure is going. So I think we need another model. As Melba said in her question, you know, there are other models for community health workers who are not students, for training your MAs to be coaches. And we'll hear about pharmacy techs as coaches. So there are a variety of models, but I think that one thing we know about students is they want this experience. They're enthusiastic. You know, they're still excited about life in a way that I may not be. And that's always really very vital feeling. And so there is a system called UC Online. And now I'm working on another consortium that's doing public health informatics training from community college, CSUs, and UC. And so I think it could be done as virtual courses. There would have to be a way for coaches to receive the device, I think, because they need to be trained on the device that they're going to then coach someone else to use. So I think that theoretically could be a rate limiting step. The cuffs that we're using are about $50, give or take 10, depending on what day you look on Amazon. So it's not incidental. So, I mean, I would definitely want to see a pilot maybe between a UC and a CSU to see if they can, you know, figure out how to do this virtually, but provide those devices at the two campuses to see if students can come somewhere and train on the devices. Early in the project, we did have devices that we kept at the library at UC Berkeley because, you know, students, they want to practice at, you know, midnight or something. So, you know, the libraries are open all the time. And so they could go and check the device out and then go and practice with one of their, you know, co-students. And that they made a video so that they could train their patient how to use the device, even virtually. So we know we did a lot of pivots and changes throughout. It doesn't make it a perfect study, but it definitely shows what's feasible and what the students are capable of doing even during a really crisis period for them, with the right team, with the right support, which Edith and Morgan did a great job of. You know, it is possible. So I'd like to see the state give it a try. UCLA has a health coach program that's through their extension, but it is a program that people have to pay, you know, to take. And so I'd like to see it something that can fit into already matriculated students where they don't have to pay extra to learn how to be a health coach and do a good job. So it's been a lot of fun. Thanks for listening.
So
Melba,
Dr. Ivey.
Sorry, go ahead.
Dr. Ivey. Yeah, this is Dr. Sky. I'll read a question from the Q&A from Melba Hinojosa, and I think it ties into what you just talked about nicely, which is, do you think the student health coaches can be classified more broadly as community health workers?
I do. And also you heard Edith using the word promotora. So I think there are unique features in different communities that make this resonate differently. And so I think we need a lot of comparison across different, you know, groups and cultures and, you know, insurance types and stuff like that. So there's plenty of room to look at different models, but I think that you can train community people as well as students. I don't think it has to be an either or. We just need to figure out which are the most effective models.
Excellent. And I'll go ahead and ask us a second question, which is a two-part question from the Q&A files. We have here from Morgan Bien. First, thank you for a wonderful presentation, of course. And then regarding participant engagement and retention, what are some of the strategies that you used for participants who may not have responded promptly? For example, not completing surveys. And then I'll ask the second part when you've had a chance to answer that.
I'll let Edith take that one because she's the queen of retention.
Yeah, I was also going to say that we're very thankful for the students, and they're so full of energy and ready to call and not give up on the participant. Sometimes I think it's difficult for these people that they don't have family members that really know the health background, and they also just feel like they need somebody there. And so these coaches just have been the source of support, and they continue to call even when the participant didn't answer the first 5 calls. They continue, they use different hours of the day. They try early in the morning and late, even after like 8 p.m. Some participants actually request for us to call them after 8 p.m. And these students are just willing to do anything that it takes to get them on the phone, get them the health coaching that they need and the support. Yeah.
Excellent.
I have a
It's
question.
wonderful to hear. Oh, it's wonderful to hear the efforts that you guys went to get results. So part 2 of that question was that thanks for answering that. It's wonderful what the extent that you guys went to get patients to respond. But regarding the data team, if you're able to, what are some of the variables or comparisons that are being analyzed? If you're able to answer that, was the second part of that question.
Well, we had proposed in the original study that the primary outcomes would be the measured blood pressure. So one thing that clearly changed was we weren't able to go in person for arm 2 people from about mid-March of 2020 till pretty much the end of October 2020. So there's a big chunk period where all we could do was ask people to submit a blood pressure from their physician or from a pharmacy or something, but we know that that wasn't our original intended way to measure. We wanted everybody to use the exact same, device to have their measures, and for it to be done kind of in a home setting, as you heard our nephrologist earlier say. We know that home blood pressures are a little lower than office blood pressures, so I'm nervous about using those not in person, ones, but we'll come up with some sort of sensitivity analysis to look at things with the blood pressures we have, but also do imputation. And we may try a couple of different ways. There's a method called last measure forward, and that assumes that you got 0 change. So if we had a baseline blood pressure on somebody and then we didn't have a blood pressure, we could carry that measure forward as a conservative assumption that there wasn't change. On the other hand, these newer methods like multiple imputation and hot deck methods are considered to be better. So, we have some opportunity for the students to both learn about new mechanisms for the analysis and also hopefully improve our ability to analyze the data. I had other colleagues who just said, I can't do my study during the pandemic. And there have been many times I've looked back and said, why didn't I say that? Yeah. But here we are 3 years later, finally with the sample size that we hoped we would have after 2 years. And we're still having fun. Thank you for having us.
So back to Bill's question about scaling up, I'm just envisioning, what if all the pre-health students, the pre-PAs, the pre-nursing, the pre-medical students had a requirement of learning how to become health coaches across the UC and CSUs, even our community colleges? Just imagine what a workforce we would build for this. Is it conceivable that you could lead such a build out, Susan, if we could get funding for a demonstration program?
I mean, I think that's what the Jeffrey Thomas Stroke Shield hoped, is that we would do a small study and we would see that it was feasible and we were getting some outcomes that were better in one arm than another, and that would be able to be scaled up. But I'm finding from my other project on public health informatics that there are a lot of institutional differences by the types of universities in the state, and they have different policies. So it may be much harder, I think, to work with the community colleges. There's definitely course curricula that would need to be done separately. Whereas I think with CSU and UC, at least for our local CSU East Bay and CSU Long Beach that I'm working with on my other project, I think there's some possibility there to use the same curriculum on the two platforms. We have one called UC Online, and they have one called S4 or something that's an online platform for CSU. So I think it's possible. I think it would require sort of state level support for faculty to be able to do that. Obviously, I couldn't do all the teaching, but to have people who are able to not just teach, but also have oversight, as you can see from all the work that Edith's done, it does require a lot of hands-on checking in, making sure people are adequately trained. We assess them all with vignettes like you would for medical students to make sure that they can respond to different types of people. But again, they've been pretty successful in their ventures, so I have confidence we could do it.
So along the lines of what Hattie just talked about, scalability, I think Melba Hinojosa's follow-up question, in addition to the question that you've already answered, is really good. Is there any way we can turn on her mic so she can ask the question herself?
We had invited her to become a panelist, and she declined the invitation. But
okay.
We could try again.
So, Hattie, do you want to read her question? Or?
No, you go ahead.
Or I can read it. Okay, so the reason she asked the question regarding the strategies under the Prevention Forward for Cardiovascular and Diabetes Prevention and Management is that strategy B.5, develop a statewide infrastructure to promote sustainability for community health workers to promote the management of hypertension and high cholesterol. If it stands like that, then the opportunity would be they're already in 7 counties. And if community health workers could be engaged in their work and contract with the project that you're doing, Dr. Ivey, would there be a way that this potentially could, allow some collaboration and scalability? I hope I did justice to the question.
Yeah, and I'll probably talk with Melba on Wednesday too, I think. So, but I think the key things are, like, in one group, people are patients and we're trying to get reimbursement, right? So that's the kind of the issue with, creating a pay structure for community health workers, is so they can be reimbursed for their work. And I don't see that being the model for undergraduate students. We have had some dollars available to pay students, mostly to act as their research assistants, but I think it's a little bit more fraught for university students to get reimbursed. Are they getting reimbursed as individuals? Is it going back to the university? I just see that as not the typical model that you would use for student coaches, but I do think it's a great model for community health workers. And obviously, if you're training your MAs to do this, it's a way to capture some, added value for the MA's work. If you can capture through Medi-Cal or something, an incentive payment for the practice.
I see that Melba Hinojosa has joined us. Thank you, Melba. Can you unmute yourself and express your question directly, please?
We can't hear you.
We're not able to hear you, Melba. If you'd like to speak up about your question for Dr. Ivey, please. It might not work. I don't know how you're muted. It doesn't show that you're muted. So I know that, she's calling in to make a second connection.
While we're waiting for that, there was another question as to whether or not this would apply for diabetes potentially, Dr. Ivey, and I would assume the answer would be yes. If you had anything more to say than just yes.
Yeah, actually, my first health coaching project was with people with diabetes, but it was using Tom Bodenheimer's model for MAs to be trained as health coaches, and that was also successful at reducing hemoglobin A1C. Not into ranges that we would think of as normal, but at least, we could see the reduction and it was statistically significant. I think a mistake I made in that project is we excluded people who had really high hemoglobin A1Cs. So people who had hemoglobin A1C over 11 were excluded. And, clearly that reduced the amount of decrease that we're able to see because we're taking off the top, portion. So in retrospect, I should have left all the high values in. I was like, 11%, who has 11% for their hemoglobin A1C?
They're your best candidates. That's who has 11%.
They're always the ones that can improve the most. So.
Yeah.
Alva, were you able to get a? Okay,
I think,
hi.
can you hear me now? Okay, great.
Yes.
So under Prevention Forward, many of you are familiar with that project, and it's funded through CDC. We're just started our 5th year of a 5-year grant. And the way that strategy is written, it's like develop at the state level this, CHW program. Well, we only work in 7 counties. That's, the amount of funding we get, then we give to partners. But that said, there are quite a few efforts in progress to develop and disseminate CHW training. And part of the thing, I've been working with CHWs for a very, very long time. It always goes back to define a CHW. And there are many different words used to denote what a CHW is. And that's why I asked my initial question. So to that end, we work with Visión Compromiso, which is a CHW organization here in California that has quite a network of CHWs. They only work in the Spanish-speaking community, and as diverse as California is, we are looking beyond that now. We're working with another organization called the California CHW Collaborative, and that's a multicultural organization also working on many issues related to CHWs, including sustainability of funding, training, their scopes of practice, depending on which area they're in. So there is a lot of work being done, and I'm really interested, Dr. Ivey, in that, and with your program, which you're working with the students, it's to me a very in-depth and intensive program compared to many CHW curriculum that I have looked at. But for us at the state with Prevention Forward, blood pressure control and diabetes prevention and management are focused. So teaching someone how to teach a patient how to check a blood pressure, the motivational training that you mentioned, how to track, monitor, and report their blood pressure findings, and then the follow-up with those patients. We do have program contractors that are doing that. Again, we're limited in the number of counties that we can be in. 7 out of 58 is not that huge a coverage. But we are working on it. And then we've also been in contact quite closely with the Department of Healthcare Services that as of July 1 now has CHWs as a covered benefit under Medicare. And I don't know all the ins and outs of how that works. I've heard it can cover up to 2 30-minute sessions, but I'm not really sure. But they have published the reimbursement rates and everything on their website. I'd be happy to share the information about the DHCS Medi-Cal benefit for CHWs. So basically, I just wanted to say it sounds like a terrific project, Dr. Ivey, and I just really see a lot of momentum on the CHW front because their value and their position on the healthcare team is really, really coming out to the front now, the way I see it. So anyway, I'm very reachable. Melvina Hoss at cdph.ca.gov and through Hattie. Thank you very much for letting me share.
Thanks, Melvin. Yeah, City of Berkeley has a program called Heart to Heart, which does draw community health workers from both the main community and also trains the public health workers. And then they work together to do events in the community. But it's very different than sort of an individually focused, one-to-one kind of intervention, which this health coaching is really, the coach and the participant get connected, they form a bond, and that becomes part of their team. So I think there are a variety of different models that key would be to sort of assess where you're getting the best reduction. So I'm ecstatic if we can get 13 millimeter mercury drops. So.
Well, I've long been interested in this topic of health coaching, and my dream is that at the state level, MELBA, so MELBA, for those of you who didn't hear it, MELBA is the Prevention Forward Lead for cardiovascular disease and diabetes for the California Department of Public Health. So my dream, which you may have heard me say before, is that the state of California develop an equivalent program to the California Smoking Quit line for hypertension, because so many people need the coaching. Susan has just identified a super cost-effective way to do this, and it now seems frankly achievable, because if they're earning credit instead of, and maybe they go on to become paid workers when they graduate, but what a wonderful thing for our overall health professions in California to, for instance, be required to learn to be health coaches before they go to medical school, because frankly, you want a physician or a nurse or a nutritionist to know how to coach. And I don't think that's ubiquitously taught.
Right. And there is evidence that medical students can be effective coaches for tobacco cessation, for instance. So, again, these are undergraduates. There are many other types of students that could be trained to do this. And I have a lot of confidence that we can test those out and be sure we have more than one good model to draw on. Thanks.
I think we should give this program a wrap. We've had such wonderful speakers, and we are over time by 26 minutes, which is sort of typical. I keep telling myself we should stop right on the hour, but when we're having such a good discussion, I hate to do that. So we are going to have another amazing program coming up on really limb preservation related to peripheral artery disease on Tuesday, August 23rd from 4 to 6 p.m. We'd love to have you with us. And Dr. David Herbert with Sutter, I'm sorry we didn't have a chance to hear about your wonderful program that you've developed for hypertension coaching. I know you said it would be long to discuss it, so maybe we can schedule you to present about the results of your program another time. Do you want to just say a little thumbnail?
Well, in 30 seconds or less, we've identified some vendors that use remote patient monitoring to coach the patients how to check their own blood pressures with an automated blood pressure cuff, which then communicates via either a device we put in their house or via their phone to a team that monitors their blood pressure and coaches the patients if they're not doing well in terms of their medication compliance, their diet, and then notifies the docs if that isn't doing well enough. So it's actually not very expensive, and it gets around the problem of trying to identify volunteers. It's been quite effective. We have some practices over 90% control. So
how that helps to explain why your numbers have improved so much over the last few years. And we'd love to have you and your team present it. So let's communicate about a time for you to do that. And thank you for being with us today, everyone. It's been wonderful. It's so nice, Dr. Ivey, to see something, and Edith, to see something that's so practical, so doable, and I think so scalable. So thank you for leading this work, and we'll see you back in a couple weeks.